First of all, let me also acknowledge the traditional owners of the land on which we meet. Secondly, let me acknowledge my colleagues from ATSE. Thank you for coming. And thirdly, let me start with a disclaimer. I'm not going out of my way to be objectionable today. But I probably will annoy quite a few of you in terms of this presentation. So what I want to talk about is this. First of all, I want to talk about four things. First of all, the state of healthcare in Australia. I'll give you some observations on that. Secondly, talk about the technologies that are emerging, as I call them. In other words, they're not mainstream yet, but are moving very fast. And then show you some examples of how those might be applied in medicine. And then finally, talk about where the disruption in healthcare is going to come from. So let me start off with the state of our healthcare. Our healthcare system, we think of it as a great government-funded healthcare system, but actually it's semi-private by now. So this graph shows you in $1980 the 25-year cost of a visit to the doctor, and you can see that by 2013, the cost of the visit to the doctor is being met half by the patient, and that curve has continued to go up. You should also look at the top line curve, which is the actual cost of a visit in inflation-corrected dollars, and that's gone up steadily. In fact, it's gone up by about 40%, but the service hasn't gone up commensurately at all. In fact, I would argue it's got worse, because as they've corporatized GP medicine, you get a slot and you have to fit in that slot, and it doesn't matter if you're dying or not, they just fit you in the slot. So that's the first thing, and if that doesn't make you angry, the second thing should really make you angry, because we have a healthcare system which is driven by the providers. So there's the famous case of the ophthalmologist who got a machine that allowed them to do something like 6 times more cataract operations per hour, but insisted on being paid the same for each cataract operation. So a 6-fold increase in the salary for actually no more work, which is nice work if you can get it. But then there's also the fact that if you look at these headlines, what patients are paying out of pocket is totally out of control, because the doctors can charge more or less what they like, and some of them are charging 10 times the Medicare fees. So we see a huge range of variation there. Then what really should make us all weep, if you look at, this is a World Health Organization data which shows the number of doctors per capita of population. And you can see that Australia is only just better. Only Africa and Indonesia are worse than us. Even South Africa is better than us. So if you compare us to New Zealand and to Canada, we roughly spend the same amount of percentage of GDP on healthcare, but they have twice as many doctors per capita as we do. So there's something wrong there, and it could be many explanations, but the most obvious one is that the supply of doctors is being controlled, because we don't lack talent and we don't lack an ability to train people. So that leaves us with a healthcare system where, as I've said, wide variety of pricing, but no actual open market where patients can determine what they're paying for and what they're getting in return. So when you pay 10 times the Medicare fee for that doctor, is he 10 times better than the next person? Is he getting 10 times better outcomes? Now go and test this on the medical system. Go and ask a doctor about this, and they'll come up with 1,000 excuses, most of which go like this: oh, all patients are different. Well, that's true. Clearly, a 25-year-old athlete is very different from a 65-year-old obese smoker. And the outcomes are likely to differ for that. But we live in a world of big data, and I'm going to come back to that, where it is potentially feasible to derive what I'm going to call a figure of merit for medical performance, using big data to take into account all the confounding influences, determine how good a doctor really is. And my hypothesis, still to be tested because no one's actually done this, my hypothesis is you'll find it's a very narrow Gaussian curve of performance with a few large outliers, probably mostly on the negative side. There is a site, by the way, now called Healthcare. It's called HealthShare, and if you ever have to have a procedure, it's worthwhile checking your doctor, because at least they'll tell you how much you're paying, not how good he is or she is. Oh, that's another tip, by the way. My son, who's in the medical profession, tells me if you have to have surgery, ask for a female surgeon because they charge less. which says something about our societies. So what are the technologies that are going to change this? Well, I'm just going to give you a summation of this. I obviously don't have time to cover it in huge detail, but they're basically a set of technologies which have the potential to change the way we do healthcare. The first is what we in the industry, telecoms industry, call the Internet of Things, which is really the fact that we've seen a plethora of low-cost sensors that allow us to measure our bodies and our environment. So that creates a whole lot of new data in real time that we can make use of. The second thing is big data, which, to be honest, is just plumbing, but the computer scientists love to talk about it and make it mystical. The way we used to do data in the 20th century was you have what's called a relational database. You have very fixed structured data with records and subfields in it. In the modern world, you just collect data at speed, in real time, in huge volumes, and most importantly of all, it's not structured. You can use unstructured text, you can use video, you can use audio, and that allows you to move one step further, and that's to create what's called machine learning. Now, machine learning is mistakenly called artificial intelligence, and people make it sound as though it's some mystical way in which a machine can emulate a human being. It's none of those things. It's simply pattern recognition. But what machine learning is extremely good at is being able to derive patterns out of data sets which are large and where there's no causal mathematical relationship between input and output, or no obvious causal mathematical relationship. And the most classic of these is speech recognition. So people have been trying to recognize speech with a machine since the 1970s. I confess that I was one of those people in this miserable period in the 80s where we tried to build mathematical models of this vocal tract and see if we could get it to match human speech. And of course, we failed miserably. And then along in 2010 comes Google and say, we've got a huge amount of computing power and we've got a huge amount of data and labeled data sets. Let's just chuck them at a neural network. And hey, presto, you can see the curve just flies up from 2010 to 2016, when IBM and Microsoft started arguing about which of them had achieved human-level recognition first. So speech recognition is a classic example of machine learning. And we will do it with other things, like being able to recognize thoughts in the future. I won't go into that. But the big win in machine learning, the huge win, the transformational win, is machine vision. So that's just that's a simple example using Google facial recognition. And because I'm a massive egotist, I took my own photo stream and said, find pictures of me. And it found pictures in all sorts of situations, contre jour, wearing helmets, etc., profile. So machine vision is really important because it enables robotics, and robotics enable various forms of automation, including driverless cars, but also automated surgery systems. And then there's one last set of technologies I need to mention, and those are gene technologies. And that curve on those green dots curve is the cost of doing a genome sequence and how it's fallen since the 90s when Craig Venter did the first sequence of the human genome. We're seeing all sorts of new devices, like you can plug into a mobile phone that's a nanopore sequencer that will do gene sequencing. And then on top of that, you've got to add all the omics, the microbiomics and the proteomics, etc., which all come into this. But I just lump all that under gene measurement. The big new thing is CRISPR, gene editing. There's some interesting gotchas emerging in the research at the moment. But the notion there is you can actually splice a gene and put in extra sequences of DNA and do things like ultimately be able to repair genetically based diseases. But that's, as I say, a bit of a gotcha. One of the interesting ones they're doing at the moment are gene drives, where they do things like, for example, change the DNA of a mosquito in order to drive it to extinction. So how will we use those in healthcare? Well, there are a number of ways, but the most interesting one that's happening right now is using the humble smartphone or not so humble smartphone as a medical instrument. So people are using the processing power and the cameras and the microphones and the screen power of a phone in order to create medical instruments like with an extra add-on. And these were originally designed for developing countries to make cheap instruments for medical carers there. But I've spoken to ear and teeth surgeon in Australia who say that's a perfectly good otoscope, as good as any you can buy on the market. The big thing that happened in the early teens was the emergence of the monitoring movement, so-called wearables. That was driven by health and wellness, mainly because there's no regulatory oversight of that, so you didn't have to go through the whole TGA, FDA thing. But what happened is in the first few years of this decade, these things got so good that they were actually producing medical grade data. And people are now starting to go through that regulation process to do things like that thing over there is a single lead ECG, which you can wear 24/7 and you swim with it and do the whole thing. So you can start collecting really useful data from it. And various companies have used machine learning on things like the Apple Watch and shown they can predict AFib with 97% accuracy and other conditions as well. The big thing we'll see coming forward, and I wish I had time to explain this because this is really cool, and it's a paper from Nature Electronics, which is being able to do passive monitoring. So, you know, this notion of being in intensive care and having a gazillion wires or hanging off you, that will go away with time, and we'll just be able to integrate the monitoring into our normal existence. The other big thing, as I said, machine vision is huge, and people are starting to do diagnostics using machine vision in all sorts of areas. So I like this example because I met these guys. It's a startup in Silicon Valley. They say that the gold standard for doing breast screening is not mammograms but ultrasound, but the radiologists don't like doing ultrasounds because it takes them much longer to evaluate than a mammogram, which according to my wife, I haven't experienced it, but according to my wife is extremely unpleasant. So there are a whole lot of good reasons to go to ultrasound, and these guys found a way of using machine vision to actually, first of all, they take a full scan of the breast in multiple dimensions, and then they can use machine vision to detect anomalies, and they say they can do it more accurately than a radiologist can. So where we're heading towards is a personal physician 24/7, someone who's going to be, you're going to have one of these strips on you, you're going to be have it relay its information straight through to a big data center where they're going to be applying machine learning algorithms, and then they'll flag anomalies and a human will be alerted, and you'll be sitting at lunch one day, judging by this demographic, and an ambulance will come in and cart you off. So probably beats dying, but it's probably a little invasive. I'm going to skip all this stuff because I want to get to this, because I've only got a couple of minutes left. And where I want to go to now is how are we going to disrupt medicine? And the answer lies in the data. So this is some work that IBM did, where they showed that the actual clinical data you collect in an electronic health record is only a small amount of data, 400 gigabytes, but it really only influences 10% of your outcomes in terms of medical practice or health outcomes. If you add the genomic data into it, that's another few terabytes, and that gets you up to 30% of the outcomes. But if you collect what IBM called the exogenous data, which is all the data in our lives, what you're eating, where you are, who you're talking to, all these things, if you just collect everything that's piling through this mobile phone, it's about, over a lifetime, it's about 1,100 terabytes of data, which sounds a lot, but is quite manageable. And it has an impact on 60% of the outcomes. So who's got that data? And who's going to make the change? Well, the obvious one is Amazon. They've got heaps of data. They've got heaps of exogenous data. And they've just established what they call in the States an HMO, which is a combined health insurance plus practitioner system. And they're pretty cagey about their plans, but you can bet initially they're starting off only with their own employees and JP Morgan's and Berkshire Hathaway. But you can bet your bottom dollar that they're going to do two things. They've already said they're going to force the doctors who work with them to use digital technology to improve their efficiency. And the second thing is you can bet that they're going to be looking for that figure of merit to judge the performance of doctors, and they're going to be paying doctors according to their figure of merit. Just as an interesting insight, they bought a company called PillPack a couple of weeks ago. For $1 billion, which sounds like a lot, but must be chump change to them. But the reason they bought it is, look at the, comes from, I think, the equivalent of Choice in the US. This is a basket of 5 prescription medicines being from different suppliers in the US. ranges from $66 to $928. The top guys there, Rite Aid and CVS, when Amazon bought PillPack, their share price dropped overnight by 10%. And you can see why just looking at that chart. So they're going to look for any disruption that they can, and they're going to find lots in the medical profession. So Google are doing a whole lot of stuff. They're mostly focused on the sort of monitoring and therapeutic aspects. I won't go into that. I'll end off there because I've used up my 15 minutes, but I just want to emphasize, I've looked at the opportunities. I haven't talked about privacy, and you'll have seen a whole lot of really stupid stuff in the papers today about privacy. You know, the Medicare will be hacked. It's a bit like saying your bank will be hacked. Yes, there's a possibility it will be hacked, but some idiotic journalist went to someone and said, can you guarantee it won't be hacked? Well, only an idiot would say they can guarantee it won't be hacked. I mean, I can't guarantee the sky won't fall in. So it's completely stupid, and that's kind of missing the whole point. It's just creating fear-mongering for the tinfoil hat brigade. But it nevertheless needs to be addressed. So you can't just ignore it, but on the other hand, it's not a showstopper. And I'll leave you with that thought because what are the showstoppers? They're not things like privacy and security. The showstoppers are whether you can overcome the vested interests in the system in order to change it. Thank you.